If the patient is having TB, there's likelihood that that patient is HIV positive, and it's vice versa. If the patient is HIV positive, the possibility that that patient can contract TB. So that's why we decided to integrate the two services.
This project started, I would say, almost 10 years ago, in 1999, to test the feasibility of treating HIV with antiretroviral in a very resource-constrained setting like Khayelitshas, where people are facing a lot of poverty and lack of resource. The most recent challenges are, of course, integration with TB. Why so? Because although it makes a lot of sense, we have 70% of our TB patients are co-infected with HIV. So two diseases, one patient. Makes a lot of sense that they are treated with a one-stop service.
Before we combine the clinic, we have seen very sick patients surfacing from the TB program, with very low CD4 count. And we thought that if this patient was under 1K, by the time they finish the initial phase on TB medication, that's the time we should have started them on antiretroviral drugs. But now, in the olden days, they have to complete the 6 months of TB medication, and then that's the only time they come to the HIV clinic.
Patients were being diagnosed in their communities but could not access treatment, and often patients disappeared or died. So we wanted to bring treatment into the community. We've put in patient support, we've put in home visits, and we're trying to have a very patient-centered management.
It lessens their journey to the clinic, because instead of coming for 2 days, for TB today and tomorrow for antiretroviral drugs or vice versa, they come on a 1 day. And to them, when they are sick, they don't need to be seen by 2 doctors. A doctor on call will see patients, irrespective of the patient is co-infected.